Great, thank you very much. It's been an enthralling morning and 2 days already. Thank you, Harry, and Yashoda Hospital for inviting me and all my friends to this wonderful location. It's a great privilege of mine to start really with bronchoscopic lung volume reduction with endobronchial valves. And I know that India is very soon going to have access to this technology, and it's a great opportunity for us to look at this work. These are my conflicts of interest, and basically this journey of endobronchial valves started over the last 25 years. One of my colleagues, Tudor Toma, myself and Duncan Geddes, we started the initial work in London, and then this work has been transformed internationally with 7 randomized clinical trials, and now it's a kind of gold standard. It's established therapy in the COPD Gold Guidelines, which are recognized for COPD all over the world. So I'm not going to go through each individual trial in immense detail, but really wanted to show you this journey where we have, in interventional bronchoscopy, done very systematic, careful evaluations to really make sure that firstly, we understand the technology. Secondly, we know what patients to treat. We know what's the complications of this therapy, and we know its advantages and its competition. The first randomized controlled study was the WENT study, where a lot of the people in the audience took part in. And when we looked at the initial data for this study, it was quite disappointing, because although it was statistically significant, what was it clinically meaningful? A 7% difference in FEV1, patients walking by 12 meters more, and a change in SGRQ scores, which is very similar to most inhalers. But actually, when we looked at, if you perform the procedure correctly and you chose the right patients, then you're getting clinically meaningful response in these patients who are actually very desperate. And you're seeing 8-point changes in quality of life, 24% improvements in lung function, and people walking significantly more than before. So the next study that we did was actually a sham-controlled study in London at the Brompton. We randomized 25 patients to the sham arm, 25 patients to the endobronchial arm, and you can see that in the sham arm, you're getting results which are very similar to some of the inhalers which have $1 billion industry. So with the FEV1, you can see in the treatment arm, there's almost 25% improvement in FEV1, considering one of the definitions for COPD is irreversible airflow obstruction. And you're seeing, once again, meaningful improvements in quality of life and 6-minute walk tests. And what we also learned in this trial, that actually if you excluded patients who were collateral ventilation positive, then those improvements were even greater. My friends in the Netherlands did a very similar study. It was an open-label randomized study. And once again, you're seeing very similar improvements. You're seeing improvements in FEV1 of more than 150 mils. You're seeing 6-minute walk test almost improved by 60 meters, which is absolutely unheard of. Then we had the IMPACT study, and in this study we treated patients who had homogeneous disease. So up until now, it was felt that patients only with heterogeneous disease were suitable for treatment for lung volume reduction. But this study shows that if you, once again, if you choose the right patient population and treat them appropriately, you are getting significant improvements in quality of life, lung function, and exercise capacity. And one of the themes you'll start to see, which I'll put together at the end, is that every single sequential trial is expanding the horizons of who we can treat, but yet the outcomes are the same. All of these patients are seeing improvements in lung function. All of the studies are showing improvements in quality of life and improvements in exercise capacity. So all the signals are going in the same direction. So this is very real. The TRANSFORM study was a very important study because it took several centers through Europe. Majority of the centers that were involved were there for the first time, so they weren't the expert centers, they weren't the Felix Hertz or the Stefano Gasparinis of the world. They were actually straight off into interventional pulmonology, and they reproduced data which was identical to the Yodas like Felix, which is again really quite satisfying, because it shows that you can spread this technology very easily in multiple hands and yet get very consistent results. And you can see again, you're seeing improvements in FEV1, reductions in lung volume, and yet over that treatment period, the control arm were actually deteriorating. Then, I always use this slide to tease my friend Kyle Hogarth. I said the real test of this study was to take the European work and involve our friends from America and see if we can reproduce the data. Now, this was actually still a very clever study in the sense that it looked at outcomes to 12 months. So none of the studies thus far had chosen such a longer term outcome. The other interesting design in this study was at day 45, we had the opportunity to look at our data, and if you did not achieve correct valve placement and the patient had been randomized to valves, you got a second chance to get it right, and therefore optimize valve placement and then look at the outcomes. And you can see in this Liberate study that at 12 months, almost 50% of patients had an improvement in FEV1 of greater than 15%. I personally think that this is quite a high bar to reach at 12 months. Similarly, you can see that all the other parameters, once again, are going in the same direction. Life-changing improvements in quality of life. So just to put this into context, if you take someone who's been suffering for quite a while and is housebound, you treat them with endobronchial valves, and now you give them back their dignity. They can go out to the shops, they can go and buy a pint of milk, they can go and buy their newspaper, and it really makes them independent compared to what they were doing before. The secondary endpoints again meet all the parameters that I've already shown you, but just to put into context, what is the main complication? Well, the main complication for endobronchial valves is pneumothoraces. And fortunately, most of these seem to occur in the first 3 or 4 days of treatment. So the main message here was, initially when I started doing endobronchial valves, we would put the valves in the morning, the patients would go home in the afternoon, but we lost a few over this period, and we very quickly realized that the main issue was pneumothoraces. So if you keep these patients in hospital for at least 3 to 4 days, you are there and you can respond to the pneumothoraces, treat them with a chest drain, and mitigate the main risk of death with this technique. The other complications which we see are those which we would get with any therapy where we're bronchoscoping these patients, which is COPD exacerbations, pneumonia. When we first started, we felt that one of the main concerns would be lobar pneumonia, where the valve would be obstructing the secretions, causing problems. But thankfully, this hasn't really been a problem, and very, very few patients had to have the valves removed for obstructive pneumonia. And then there are other small things like airway kinking, expectoration of the valves, but that should also be less of a complication since the valves have undergone some refinements and we now have some low-profile valves which fit the airway more snugly and therefore less likely to be expectorated. Now, one of the other things we saw was that actually very early on that there was possibly a signal on mortality. Up until now in COPD, only oxygen therapy and transplantation has been shown to have a survival benefit. But what we saw, that patients we had treated initially with endobronchial valves and had developed atelectasis were more likely to have a longer survival compared to those who did not receive atelectasis. And then my friend from Heidelberg managed to replicate the data with just the huge numbers of patients. And again, once again, you can see that patients with atelectasis had a much better survival than those who did not. So to put all these data together again, what you're seeing is very consistent improvements in FEV1. And if you put this in context with surgery, my personal feeling is that surgical lung volume reduction is extremely successful. And if you look at the net data in the right way, you're looking at improvements in FEV1 of almost 27%. You're looking at improvements in exercise capacity of 42 meters and incredible improvements in SGRQ of almost 13 points. If you then look at the data for valves, you can see that they're almost matching the same outcomes. So what this tells me is that, number one, volume reduction, by whatever means, providing you do actually achieve volume reduction, will lead to quite significant benefits in patients. And now, really, we have a non-invasive option of endobronchial valves. And the research thus far has shown that it's essentially unilateral occlusion that we aim for. We can treat both heterogeneous and homogeneous patients. The main caveats is that these patients have to have intact fissures and absence of collateral ventilation. But we've been pushing the boundaries a bit more, and if you look at patients with a fissure that's partly disrupted, i.e. by less than 15%, we can inject a sealant, so AeriSeal, into the area where there is the least fissure integrity, and then you can see following fissure sealant, if you then put the valves in, you basically get further volume reduction. And we've done a trial, and the preliminary data again shows that you are potentially able to convert 3/4 of these patients, thereby expanding the population that can be treated with endobronchial valves. The main complication of this therapy is a pneumonitis that occurs in a small proportion of these patients. So the new algorithms that we go for are, if they've got complete fissures, then we will proceed directly to valve treatment. If they've got incomplete fissures which are greater than 20% incomplete, then we will look for alternative therapies such as surgery. And in that borderline group, we can evaluate them further, and they may potentially have a sealant target, which may then allow us to treat them with endobronchial valves. And finally, I just wanted to mention the surgery versus valves trial that we conducted in London and the rest of the UK. And the main message here is equipoise, that these patients who are suitable for both therapies seem to have similar outcomes irrespective of what therapy you choose, both in terms of lung volume reduction, exercise capacity, but also mortality and complications. And basically, I'd like to stop there, and then I'd hand over to my colleagues who will expand this therapy to other areas. Thank you.